Hello, I'm Hanifa Juso. I'm visiting fellow at Istanbul International Research Center, Turkey. I'm from Malaysia. Today, I would like to talk about traumatic distal radioulnar joint instability. I would like to talk about the general overview of the anatomy, the DRUJ biomechanics and its controversies, the treatment algorithms for the DRUJ instability, and issues related to ulnar styloid fracture. The DRUJ is important for forearm motion, especially forearm supination and pronation, and force transmission across the wrist joint. It consists of two bony components, which are distal radius and distal ulnar. The distal radius consists of the scaphoid facet, lunate facet, and scaphoid notch. And the distal ulnar consists of ulnar styloid and ulnar fovea. However, these two bony components are inherently unstable because of the differences in the sigmoid notch radius curvature and the ulnar bone heads. Apart from the radius of curvature of the ulnar head of the ulnar is more rounded compared to the shallow radius curvature in the sigmoid notch. As we can see here, the radius curvature sigmoid notch is more shallow compared to the radius curvature of the ulnar, which is more rounded. As we see from this CT scan, radius curvature of the sigmoid notch is shallower as compared to the ulnar head. The cartilage is present in 90 to 135 degrees of the ulnar head. Because of the inherently unstable DRUJ, apart from the rotation movement during pronation and supination, there will also be translation movement. In extremes of pronation and supination, there may be less than 10% of contact between these two bones. In pronation, the distal radius translates to 2.8 mm volar, which makes the ulnar head more prominent dorsally. In contrast, during supination, the radius translates to 5.4 mm dorsally. The ulnar bone is like a flagpole, and it is thick. The one that moves is the radius bone. However, generally, by convention, we always describe the position of the distal ulnar. For example, we usually describe dorsal subluxation of the distal ulnar in the case of the DRUJ instability. Because of the inherently unstable joint, the bony components alone are not enough for its stability. It needs soft tissue components also for its stability. This picture shows a nice diagram of the DRUJ with its intrinsic and extrinsic stabilizer by Dr. Clement as part of the soft tissue component of the DRUJ. Extrinsic stability of the DRUJ consists of dynamic tensioning of the ECU tendon, semi-rigid ECU tendon sheath, pronator quadratus muscle, and interosseous membrane, especially the distal oblique membrane component. Intrinsic stability of the DRUJ is by TFCC, triangular fibrocartilage. The FCC have two components. Superficial component, which is a green color, is attached to the ulnar styloid, and its deep component, which is attached to the ulnar fovea. The FCC originates from the lunate fossa and sigmoid notch and is inserted into the ulnar styloid and ulnar fovea, as I mentioned before. It consists also of the articular disc, dorsal radioulnar ligament and palmar radioulnar ligament, ulnar carpal ligaments, which are ulnar lunate and ulnar tricotal ligaments, ECU sheaths, and meniscus homologue. Articular dysfunction of the FCC is important to transmit 20% of the load across the wrist joint, whereas another 80% of load transmission is by radiocarpal joint. The two most important components of TFCC is deep component of TFCC and also the dorsal radioulnar and palmar radioulnar ligament. The initial two landmarks biomechanical study of TFCC is done by Chin and Ekenstam show a different result. The study by Chun showed that proximal radioulnar ligament is tight in supination and dorsal radioulnar ligament tight in pronation. In contrast, Ekenstam and Haggard studies show proximal radioulnar ligament tight in pronation and dorsal radioulnar ligament tight in supination. Later, they performed another study from a different perspective and showed two components of the FCC act differently. During supination, superficial palmar radioulnar ligament and deep dorsal radial ligament are tight. Superficial palmar radioulnar ligament functions to guide the ulnar head to translate volar during supination, and deep dorsal radioulnar ligament components are important to prevent further pathological translation causing DRUJ instability. In contrast, during pronation, superficial DRUL and deep palmar radioulnar ligament are tight. Superficial dorsal radioulnar ligament function to guide the ulnar head to translate dorsally during pronation, and deep palmar radioulnar ligament components are important to prevent further pathological translation causing DRUJ instability. Traumatic TFCC injury can be classified according to Palmer classification as 1A central tear, 1B avulsion injury plus minus ulnar styloid fracture, 1C distal avulsion of the ulnar carpal ligament, 1D avulsion radial insertion, and 1E degenerative central perforation. Studies about the blood supply of the TFCC show the FCC only receives blood supply around its periphery, causing the central part to be avascular. Based on the study of its blood supply, the central tear of TFCC usually is not repaired. What are the causes of the DRUJ instability? The patient may be presented with DRUJ instability with ulnar stellate fracture, injury associated with fracture as in glacis fracture, isolated acute DRUJ injury, or chronic DRUJ injury. In general, the DRUJ instability also can involve bone components, whether intra-articular or extra-articular, and also soft tissue components. However, it is also important to recognize ulnar-sided wrist pain that is not from DRUJ. You have to look for another differential diagnosis of ulnar-sided wrist pain. For example, osseous component, fracture arthritis, ligamentous component, intercarpal or TFCC injury, tendinous component, tendinitis, subluxation, vascular, thrombosis, neurologic due to nerve entrapment, or other cause like tumor. History and physical examination is important for the proper assessment of DRUJ instability. The patient may complain of DRUJ instability with ulnar-sided wrist pain, limited pronation and supination following acute trauma. They may also present in chronic conditions following previous trauma and treatment. On physical examination, the patient may present to you with prominent ulnar bone dorsally. The fovea sign is the tenderness between the depression area between the ulnar styloid and pisiform bone associated with TFCC injury. A piano key sign is demonstrated by asking the patient to put their hand on the flat table, palpating prominent ulnar styloid downward, causing returning of the ulnar styloid to its original position dorsally. The ulnocarpal stress test is done by extending the wrist with ulnar deviation resulting in pain. This DRUJ instability may be associated with ulnar abutment syndrome. Compression of the DRUJ joint may result in the improvement of pain in the case of DRUJ instability alone. However, with associated DRUJ arthritis, the crepitus may be felt with worsening of the pain during pronation and supination movement. ECU subluxation or injury also must be ruled out. ECU may be sublux or snap during pronation and supination in ulnar deviation. Press tests described by Lesser in 1995 showed 100% sensitivity to rule out pathology of ECU tendon. The patient is asked to grip the chair in pronation and push off the body weight. The ECU synergist test is also important to rule out ECU tendon pathology. The resistus thumb radial deviation is performed with the forearm in neutral position. This test may distinguish between ECU and intra-articular pathology. A negative ECU synergy test and provocative maneuvers may warrant an MRI examination to look for other intra-articular pathology. Evaluation of DRUJ instability can be done by plain radiograph, CT scans, MRI, and arthroscopic examination. PA view of radiography should be done in 90-degree shoulder abduction, 90-degree elbow flexion, and the X-ray beam directed towards the wrist in neutral position. A view radiograph may show a fracture base of ulnar stellate fracture, may show the DRUJ widening and more than 5 mm proximal displacement of radius, which are usually associated with the DRUJ instability. The DRUJ widening and instability may be obvious radiographically. However, in certain conditions, it may be subtle. The lateral X-ray view shows no obvious dorsal ulnar translation. However, a true lateral view of this X-ray shows dorsal ulnar translation. It is important to obtain the true lateral view of the wrist X-ray. The palmar border of pisiform should be in the middle third between the distal pole of scaphoid and the palmar border of capitate in the true lateral view X-ray. 10-degree deviation from true lateral may reduce accuracy to diagnose the DRUJ instability. CT scan can show better bony geometry of the DRUJ joint, especially the sigmoid notch and volar and dorsal translation of the ulnar bone. MRI can show better intra-articular soft tissue pathology like the FCC injury and other associated conditions like scapulohumeral ligament injury and ulnotracheal ligament injury. Do we need to fix the radial? Do we need to fix the ulnar stellate fracture? As I mentioned before, the FCC has a superficial component which is attached to the ulnar stellate and a deep component which is attached to the ulnar fovea. The deep component of TFCC is very important for the DRUJ instability. The avulsion fracture of the deep component of the TFCC may show as the flex sign in the X-ray. In the case of distal radius fracture associated with ulnar stellate fracture, multiple studies have shown the same functional outcome whether the ulnar stellate is fit or not after fixation of the distal radius. Apart from that, most of ulnar stellate non-unions are asymptomatic. So the most important is the assessment of the DRUJ instability after distal radius fixation. Without global DRUJ instability, which is unstable in both dorsal and volar translation, it can be treated non-operatively. For example, in the case of dorsal subluxation of the ulnar head alone, the ulnar head is unstable in pronation but stable in supination due to volar deep radioulnar ligament becoming tight. So it can be treated with a long arm cast in supination for 4 to 6 weeks. The globally unstable DRUJ in both pronation and supination, ulnar stellate fragment needs to be fixed. A large ulnar stellate fragment can be fixed with close reduction, percutaneous pinning, or screw. If failed close reduction, internal fixation using K-wire and circulate as tension band technique principle can be used. Open repair TFCC or pin DRUJ is advisable in small ulnar stellate fragment associated with global instability. In certain conditions, After visiting the distal radius and ulnar solid fragment, there is still DRUJ instability. As in this X-ray, after fixation of the ulnar solid fragment using a tension band principle technique, there is still DRUJ instability. Fujitani et al. First described the concept of radial translation as a prognostic indicator for DRUJ instability based on pre-reduction injury radiograph. A further study done by Rose et al. Found that with the correction of the bony anatomy anatomically in light of assessing the presence of radial translation deformity, any instability of the DRUJ often resolves. The radial translation of the distal fragment with the ulnar translation of the proximal radius shaft relative to the ulnar may lead to distensioning of the pronator quadratus and the distal oblique bundle of the interosseous membrane, causing DRUJ instability. For the study described by Rose et al. Also described radial translation concept using percent of lunate radial to the line. It was measured by drawing a line along the ulnar aspect of the radius shaft proximal to metaphyseal flare and extended distally through the proximal row of carpus on the PA radiograph. This line intersects the lunate. The point of intersection was evaluated by drawing a second line along the transverse width of the lunate on the AP radiograph parallel to distal radial articulation. The point of intersection of these two lines was measured from radius side of the lunate to determine the percentage of lunate radial to this point. So, in the case of acute dislocation or instability, you need to test DRUJ instability in forearm pronation and supination. Close reduction may be tried first. If reducible and not globally unstable, can mobilize in the long arm cast in stable forearm position. If unstable in all forearm positions, K-wire fixation in mid-supination followed by a 6-week long arm cast can be applied. However, in certain cases, open repair TFCC is needed, like in contact injury causing irreducible DRUJ dislocation that may be caused by entrapment of ECU, EDM, or TFCC fibers. Open repair TFCC is done by injecting the retinaculum over the fifth dorsal compartment, exposing extensor digiti minimi. The ulnar-base capsulo-retinacular flap is incised, leaving the ECU sheath intact. The deep components of TFCC was reattached to the fovea base of the ulnar styloid. This is open technique described by Kleeman, showing reattachment of the TFCC to the ulnar fovea using the anchor suture and then 2K wire cross DRUJ. RUJ et al. Described arthroscopic TFCC repair with its repair technique. He described wrist arthroscopic with olive distal radius fracture. After fixed distal radius fracture, arthroscopic was used to see the congruity of the distal end of radius joint, and also is there any asserted TFCC injury. If there is periphery tear of the TFCC, so Acute repair of the TFCC can be done at the same setting. Technique can be used is outside in or inside out repair and repair of TFCC to the joint capsule. Which all describe study of arterial TFCC repair. The result, 13 patients with 1B unassided TFCC tear showing good and excellent outcome in 12 patients, 1 patient fair result, and achieved near full range of motion in forearm rotation with 78% of the grip strength. However, further study done, a study comparing arthroscopic repair and open repair showed no significant difference in clinical outcome. However, open repair is associated with an increased rate of superficial ulnar nerve pain. However, in both groups, 14 out of 70 patients need reoperation of the DRUJ instability, causing the rest of the question if the TFCC repair is inadequate. As I mentioned before, TFCC have two components, superficial component and deep component. The previous study showing quite high number of reoperation rate may be because of the deep component of TFCC is not repair, especially and sometimes because of it cannot be viewed by the arthroscopy. So after that, the iceberg concept was introduced by Andrea Zay, mentioned that distal portion of TFCC formed by distal portion or superficial component of TFCC formed by ulnar collateral ligament and superficial fiber act as a hammock and shock absorption that usually can be seen and repaired. However, the deep component that cannot be seen is more important as the DRUJ stabilizer. A histology study by Nakamura shows the deep component of TFCC attached to the ulnar fovea that is important for DRUJ instability. The deep component not attached to the ulnar styloid but to the head of ulnar over the ulnar styloid. In the case of chronic dislocation or instability, we need to assess for radius malunion, ulnar styloid fracture, joint congruity, sigmoid notch morphology, and arthritic changes. Garcia Elias described four-leaf clover algorithm concept in managing DRUJ instability. Is there any bone deformity, cartilage damage, TFCC injury, or unstable ECU tendon? Bone deformity can be caused by distal radius malunion or abnormal sigmoid notch morphology. The bone must be corrected first, then DRUJ was assessed. If still DRUJ instability, TFCC repair or dorsal radioulnar ligament reconstruction can be done. In the presence of DRUJ arthritis, DRUJ procedure, Bower technique, Bower, cervical pangea or arthroplasty can be done. Abnormal sigmoid notch morphology may cause chronic DRUJ instability. Sigmoid notch reconstruction is needed in this kind of cases. Without global instability, dorsal radioulnar ligament reconstruction can be done using surgical technique described by Shaker et al. However, in the case of global instability, anatomic DRUJ reconstruction as described by Adams and Burgess is the best technique to tackle both volar and dorsal radioulnar ligament. This is the technique, Adam and Berger surgical technique for DRUJ instability, in which volar and dorsal radioulnar ligament was tackled and also deep, and then there is inserted into the fovea of the ulna, mimicking deep fiber of TFCC ligament incision. So it is important to restore osseous anatomy relation of DRUJ. Surgery must be done for arthritis, and it is important to stabilize the joint and the tendon. In the case of ulnar carpal abutment with DRUJ instability, a biomechanical study by Maso Nishiwaki showing that shortening 6 mm up to 44% may increase DRUJ stiffness and stability. However, if there is complete disruption of radioulnar ligament, ulnar shortening osteotomy may be unaffected. Ulnar shortening can be done first, then reassessing DRUJ stability. This is my personal case. This is a case presented in my hospital in Malaysia. A 22 years old woman presented to us with right wrist pain and instability following Galeazzi fracture fixation in another hospital. Plating right radius and K-wire cross DRUJ was done in another hospital 17 months ago. And patient come to us because of wrist pain and instability. On examination, there are gross instability of DRUJ in volar and dorsal direction, and also in full supination and pronation. After removal of K-wire 6 weeks, 1 month, 6 weeks later, the patient still have DRUJ instability, but come to our center after 70 months post-injury. Plating was removed and anatomic DRUJ reconstruction using palmaris longus tendon was done using the surgical technique described by Adams and Burgess. 6 months post-operation, this patient showing no more DRUJ instability with almost full range of motion, nearly full pronation and supination with no more unassided wrist pain. Assess the stability of the DRUJ. Deep component of TFCC, dorsal and palmar radioulnar ligaments are important stabilizers of the DRUJ. Through lateral radiograph is important to diagnose DRUJ instability. Anastomotic fractures can be treated non-operative if DRUJ is stable post-radius bone fixation. Restoring bony relationship and buttress the fracture site is important before assessing the DRUJ stability. These are my references. Thank you for your attention.